Okay. All right. First and foremost, Happy New Year, everybody. This is our very first class this year, and we've come quite far from where we started, and hopefully we can progress more from here. With that said, I have before we begin our class today, before we touch on the content for our class today, I just have an idea uh, for our classes. For some of us or most of us, well, I'm going to graduate soon, right? And uh, those who are here will be the next set of generation who's going to teach or who's going to be around, at least if anybody, if the younger generation would have any academic difficulties and all that. So I was thinking if we really want to push this class or make this something that is bigger than it is right now, in the long run, if we want this to be something that is sustainable, you guys would need to teach as well. So uh, if you guys are up for it, we can talk more about how you can teach as well. The whole idea is uh, to teach so that the next person can teach. To teach to teach. Yeah, I don't know if that's even the English for it. You're teaching to teach. I don't know. But if you're interested in doing that, we can talk more about it and organize something that is bigger. Next semester, I think I will be freer. I'll be I'll be take I'll be retiring from my from my responsibilities as GC leader soon, and so I'll have a little bit more ample time to work on it on this if anybody's interested to teach. So yeah, just throwing this out there. If this is not going anywhere, it's fine. If this is going somewhere, let's talk about it. Okay. Anyway, anyway, uh, last 2 weeks, or was it last week, we talked about infective endocarditis, yeah, and we touched on pericardial diseases. And also, I don't remember if we talked about myocarditis. Did we talk about myocarditis? Anybody remember? Yes.
I don't think so.
Okay. But what I'm sure is that we've talked about infective endocarditis very extensively, and we talked about pericarditis. I sent in the group the European Cardiology Society of Cardiology latest guideline. It's not really that latest. I think the latest one is what I sent in the group. I think it is 2000 and let me check 2015. From 2015 till this year to 2021 or 2020 at least, there was no update whatsoever. So I guess this is the latest guideline for any pericardial diseases. If you open in the guideline, if you open the guideline, you see that what we covered last week, it was mostly on acute pericarditis, acute bacterial pericarditis. And remember, I said that there are many causes of pericardial diseases. Can be viral, can be bacterial, and whatnot. So if you open the guideline, you see that pericarditis itself can be divided into acute pericarditis, incessant pericarditis, recurrent pericarditis, and chronic pericarditis. And they also, it's in the table the criteria so the diagnostic criteria for each form of pericarditis, and so that you know what what makes the cut for all these subcategories of pericarditis. There are also some other diseases that we talked last week. We talked a little bit on pericardial effusion. In the criteria, the pericardial effusion, one second, the pericardial effusion is of course more in detail. And of course, when you talk about pericardial effusion, just like pleurisy in the lungs, there's dry pleurisy and wet pleurisy, right? As we all know. And when it comes to wet pleurisy, there are also different types of exudates or all these gooey, fluidy things in the in the pleural sac, and yeah, pleural sac, or the, what's that space called? The pleural cavity. Why am I losing my word? In the pleural cavity. And so the same principle is also applied in pericardial effusion. Everybody knows what pericardial effusion is, right? It's an accumulation of something within the pericardial sac. Pericardial sac, it means that it's the same way between the visceral pericardium and the visceral and, why am I losing my words? Visceral and parietal pericardium. So all this, the things that can accumulate in the sac can be transudate, can be transudate. What's the other one?
Exudate. I don't know.
Transudate, transudate, exudate, not exudate. Is that the word?
It is.
Is that the word really? Why am I losing my word today? I don't
Yeah,
understand why.
I think
Okay,
so.
okay. Transudate, exudate. In USMLE at least, it talks about translate, exudate, serosanguinous, and fibrinous pericarditis. But the thing is that all these four types of things that can be accumulated, so-called things that can be accumulated in the pericardial sac. For example, first and foremost, the exudative, no, the transudative pericarditis. It is mostly uh, it is mostly, why am I losing my words? I don't understand why I'm losing my words. Um, it is mostly clear fluid. It can be lymph. It can be proteins and whatnot. While exudative can be any other things like pus and stuff like that. Serosanguinous is more specific to tuberculous pericarditis, and fibrinous pericarditis. Some of you might have heard fibrinous pericarditis, just like fibrinous pleurisy or dry pleurisy. Um, the term fibrinous pericarditis in the guideline here is practically non-existent, and they use the name constrictive pericarditis instead. Another thing that can be accumulated inside the pericardial sac is something it's called frank blood, or just blood. It is more common in trauma, and it's more common in congestive heart diseases. So there's just so many things that can be accumulated in the sac depending on the etiology of the pericarditis. And this is like a cascade kind of thing. It starts with pericarditis, then and effusion, and then tamponade. And it gets more serious and as it develops. So if you now let's if you would like to open the guideline, we're not going to go through the guideline because it's very extensive, and if we want to talk about it, it's very it's going to be very long. There are other forms of pericarditis as well. They are of course not as common: radiation pericarditis, chylopericardium, drug-related pericarditis, pericardial effusion in metabolic and endocrine disorders, and pericardial involvement in pulmonary hypertension. And pulmonary hypertension, it's very common in congestive heart disease. And lastly, pericardial cysts. Pericardial cysts. Now, when it comes to acute pericarditis, if you remember, when we talked about the treatment, we mostly talked about NSAIDs and all that, right? But in this guideline, they it recommends using colchicine instead of NSAID first. Colchicine is actually not an NSAID, but uh, not essentially an NSAID, but uh, it was proven that it is useful in um, the treatment for it is more useful than to use the normal NSAID. 1 second, let me mhm. Right. I just wanted to confirm something. Yeah, colchicine is actually not an NSAID. Uh, it is derived from a plant, if I'm not mistaken. It, it's purple in color. I forgot the name of that plant, but it is not it is not an NSAID, and it is commonly used in gout, colchicine, for especially with the the painful toe problem in gout, and also in your ankle joint as well, alongside your allopurinol as well when it comes to gout. But well, we're not going to talk about gout today. But anyway, let me see if there are any things that I want to point out.
Naman,
Hmm.
does this colchicine works for all type of effusion?
No, this is just for pericarditis, not effusion.
Oh, okay.
And colchicine in this, by the way, the colchicine in this case will be in tablet or IV form, but mostly will be IV or IM. But bear in mind, the colchicine that we use in gout is not IV. We use colchicine for gout will be just in gel form, and there are specific criteria to use the gel form. It's like one tube. You have to press 2-3 centimeter, then you apply on the joint and stuff like that. Well, that's for gout. But you can, if you're interested, you can read more on how to use colchicine in pericarditis. We're not going to go deep into it because it is actually very deep. But yeah, again, for cardiac tamponade, we've talked about how to take the fluid out, right? Pericardial synthesis, because it is an emergency situation. Another point that I would like to cover, because these are all new points that are not in the board exam and stuff like that. Just wanted to point it out, just to, did I miss out on anything? Uh-huh. What this surgical procedure is called pericardiectomy, removal of the pericardial um removal of the parietal pericardial parietal pericardium. Or in It's not, from the name itself, it suggests the removal of the the pericardial layer, right? But essentially it's not. So what it is that it's just to create a so-called pericardial window so that there'll be a proper drainage of the of what is contained in the pericardial sac, and it just goes out. So that's pericardiectomy, and it's not and actually removal of the pericardium. Anyway, that is just a brief run through of what we've covered before. If we've not covered myocarditis. Oh, by the way, in pericardial diseases as well, when it comes to the inflammatory processes of the pericardium, of course, we talked about NSAIDs, right? And if it is not effective, we can proceed to give glucocorticoids as well, corticosteroids as well, to increase the effectiveness of the um, anti-inflammatory effect. However, However, in myocarditis, your corticosteroid is actually not used. Actually, it's also contraindicated. The same way that there are so many different causes of pericarditis, for myocarditis as well, it is also there are also many causes, um, and it can be viral, it can be bacterial, it can be parasites and stuff, autoimmune as well, drug induced, just like in pericarditis, the same way, the same thing that we covered in the causes of pericardial diseases. And the way we treat myocarditis is also the same, except glucocorticoids are not preferred. Okay, I also would like to point out that in the guideline that I sent to everybody, there's this term called um, constrictive pericarditis. Constrictive pericarditis, which I mentioned earlier on, is also synonymous to fibrinous pericarditis. And I was contemplating whether I should or whether we should talk about constrictive pericarditis today, but I think it would be better when we talk about cardiomyopathy, because the thing is that the clinical picture, the clinical manifestation, and the diagnosis and everything, constrictive pericarditis and restrictive cardiomyopathy, it's almost the same. It is almost the same, and it's important to know how to differentiate that. So I think it would be better for us to talk about constrictive pericarditis when we talk about cardiomyopathy. There are three types of cardiomyopathy: your restrictive cardiomyopathy, your hypertrophic cardiomyopathy, and your
Dilated.
dilated cardiomyopathy, right? Your dilated cardiomyopathy. So we'll talk about that later on. If I forget to talk about constrictive pericarditis when we talk about cardiomyopathy, please do remind me. As you can see today, I don't know why. Uh,
Um,
I'm a bit. Uh, Probably it's the holiday. And
Norman. So constrictive pericarditis is the same as fibrinous pericarditis,
mm-hmm.
and it's almost the same as restrictive cardiomyopathy.
Yes, the clinical manifestation is the same. The only way that you can differentiate both of them is through your echocardiogram and also biopsy actually.
Okay.
But well, we'll talk about that later on. All right. If we don't have any other questions or any confusion, can we move on to rheumatic fever?
Yep.
Okay. All right. Rheumatic fever. Rheumatic fever is a very, very important disease, group of diseases actually. Um, it's because it's very common, and based on the epidemiology, it is often see in kids instead of adults between 5 to 15 years old. And as the age becomes older, the rate of occurrence is a bit low. So between 5 and 15, it's the it's the highest number of patients, and we see that there is a higher number of patients in this set of people. So we can say that this is mostly a pediatric um, problem, but then again, I think it is still important to know about it, and because in the long run, these kids will still grow up, and if it's not detected or understood, then it is still a problem. So that is why it's important to talk about it. Now, all right, before we go in depth about on rheumatic fever, I would like to talk about microbiology for a bit. And it's important because of course we studied microbiology when we were like what, second year or something, or was it third year? I think it's second year, somewhere there. And as we become older, we forget this little basics, and sometimes some terms are being thrown around, and it's these are just terms that that pass our mind, and we might not even pay attention to it. So there are some terms that we've heard before, like beta hemolytic streptococcus, alpha hemolytic streptococcus, group A beta hemolytic streptococcus, and the very famous one, group A um, beta hemolytic streptococcus, or group B, and stuff like that. And uh, for a second year student, probably it makes sense, or or not at this point. But um, it's important to know why they are called that way. And if you already know, well, good, bravo. And but we are going to go through them still. But anyway, streptococcus. Streptococcus. I would like to just talk about streptococcus. Of course, the pointers that I posted in the group, I posted both streptococcus and staphylococcus, right? The difference between both of them would be some reactions. Catalase reaction, one is negative, one is positive. Streptococcus is negative, and staph is positive. But these are just more of detailed microbiology, which I don't think we will. I don't think it is very clinically significant, but I'm just going to point out what's clinically significant. Okay. Uh, Cultural properties as well. Stuff is grouped together like a bunch of grapes, right? Remember? Whereas streptococcus, they are in chains. They are, yeah, chain like, they are usually arranged in chains. So let's talk about streptococcus. They are both strep and staph is they are both gram positive, of course, and they both pose the same amount of problem to 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 mankind, and we need to develop antibiotics, good antibiotics to go against streptococcus and stuff. And we've talked about this, right? And how this bacteria becomes smarter, and they form some form of resistance against the antibiotics that we prescribe. MRSA, for example, which we've talked earlier on, right? MRSA, your methicillin resistant staph aureus. But we're not going to talk about staph today. Let's talk about strep today, because I think we talk about staph a lot. Streptococcus. Streptococcus, it generally is divided into aerobic streptococcus, facultative anaerobes, and obligate anaerobes. But that is not, and that can be significant for For some diseases, for example, facultative or obligate anaerobes, they are, for example, your obligate anaerobes, your enterococci, they live in your gut, and there it's almost there's almost no not enough oxygen there. So they can be facultative. I think they are facultative anaerobes, but yeah, whether it's aerobic, anaerobic, it it's this property does still play some extent some clinical significance. But I would like to talk about the hemolytic properties of Streptococcus. The Another set of classification or ways to describe or ways to put or group your Streptococcus is your alpha hemolysis, beta hemolysis, and gamma hemolysis. Now, what does this mean? So I trust that everybody knows what hemolysis mean, right? Hem, blood. Lysis means to break, right? So hemolysis, the property uh, to break down your RBC, your erythrocyte, your red blood cell. So it is described based on the blood culture that we inoculate over. So your alpha hemolysis is is the strain of Streptococcus partially uh, that partially hemolyzes blood. Your beta hemolysis are streptococci that completely hemolyze blood, while your gamma hemolysis is basically no hemolysis at all. So it does not hemolyze blood. Now on the blood agar for alpha hemolysis, you see that let's say you inoculate like this, yeah, on the agar. And by the way, the entire medium is blood, yeah, the entire medium is blood. So what happens is that you see that around the area of inoculation, you see some like fences around it, and it's closer to the area of inoculation, and it's green in color. It's green in color. So if you see that it's green, it means that and it's closer to the area of inoculation, it means that it is alpha hemolysis. And groups of this group, alpha hemolytic streptococcus, it includes your streptococcus pneumonia, and streptococcus viridans. Pneumonia and viridans. So from the name, you know what it causes, right? Pneumonia. Okay, this is alpha hemolysis. Beta hemolysis, it is when it completely hemolyzes, right? So the same way, if you inoculate like this, and you just imagine everything is red, yeah, everything is red. Then after a while, you see that the borders is actually quite far from the area of the inoculation, and it is clear. No, not there are no clear demarcation, or like it does not have any fence, so-called fence, just like your alpha hemolytic streptococcus. And because it's clear, it means that it completely hemolyzes, right? So the most common strain of beta hemolytic Streptococcus, and that we all know is Streptococcus pyogenes. Streptococcus pyogenes it causes a lot of things. Can cause your tonsillitis. It can cause your pharyngitis. It causes your it causes otitis media. It causes erysipelas. It causes a lot of things. A lot of things. Erysipelas is a skin problem. I'm not really sure if everybody remember us talking about it. I'm not really sure whether it was in peds or was it in dermatology. But anyway, I think it was in peds. Erysipelas and well, all of this falls under beta hemolytic streptococcus. Now, that should I move on? No. Uh, Besides that, there is also a way to subclassify your beta hemolytic streptococcus, and it's called Lancefield classification. Lancefield classification, basically it is a um, serological classification. Basically you send in just to the lab. You don't do anything, and basically the lab people do it. But based on the classification, it classifies beta hemolytic streptococcus from A until J, or is it, or until L, except for I, and I don't remember another alphabet, but from A B C D and up to an alphabet. It's not clinically significant, but uh, there is there are just a lot of it under your beta hemolytic streptococcus, and the famous one would be your that's why we always hear group B or group A, um, streptococcus, group A or group B beta hemolytic streptococcus. Group B is your stuff, your streptococcus pyogenes. Don't remember group A. Group A is, don't remember group A. Anyway, group B is your pyogenes. So that is why the names that we always hear, it falls under this, right? Your gamma hemolytic streptococcus, they are your enterococci. It does not hemolyze any red blood cells, and we're not going to talk about it. I'm just going to throw it out there that they are enterococci. So yeah, so that's that. So I hope that's clear, and that the terms that we always hear, it now makes sense. The next thing that I would like to talk about that I believe is very clinically important when it comes to rheumatic fever is to understand the factors of virulence of streptococcus. And I'm going to specifically talk about Streptococcus pyogenes now, not other forms of Streptococcus, because different Streptococci, they have different factors of virulence. I don't really like the term factor of virulence because they are bacteria, they are not viruses. So the factor of virulence, we learn about it in micro B. It uses the term virulence. It sounds weird to me, at least. Uh, I think it sounds better for us to use factor or pathogenicity, because that makes more sense than using the word virulence. But anyway, there are specific things that can cause problem in the body that Streptococcus pyogenes does. There are specific things, and if you like to write this down, you can write as well. Number one would be the capsule of of Streptococcus pyogenes. It functions to prevent Phagocytosis, yeah. You know, when any foreign substance or foreign antigen gets into the body, our immune system will send in your macrophages for it to engulf, right? And to swallow, to eat. And the capsule functions to prevent that. Next will be your M protein, the same function as well, but the M protein, the capsule at first is mostly on the cell wall of strep pyogenes, while your M protein is mostly in the flagella of the strep pyogenes. The same function. There are also another protein called M-like protein, just like your M protein, the same function as well. There are some specific endotoxins and exotoxins as well, like pyogenic endotoxin, your streptolysin. There are two types of streptolysin, streptolysin S and streptolysin O. And this streptolysin is the one that breaks down red blood cell. The hemolytic property that we talked about earlier on, it's because of streptolysin S and O. This is important because we are going to talk about diagnosis early on. Just remember all these factors of virulence, okay? Next will be streptokinase. Now, I want to ask everybody here. I trust that everybody has heard this name before. Streptokinase, what is this thing?
Enzyme.
Okay, it is an enzyme. ACE, right? ASE, enzyme. And does it sound like a name of a drug?
Yes.
Yes.
Okay, which drug?
A thrombolytic drug.
They are thrombolytic or fibrinolytic, right? And can anybody name other thrombolytic or fibrinolytics too, besides streptokinase?
Warfarin, heparin.
Those are anticoagulants. Fibrinolytic. Anybody? You can name me 3. Streptokinase is one.
Altiplase.
Okay, streptokinase, altiplus, and
Purolase.
what?
Purolase.
Purolase. I've never heard of that before.
Okay.
Urokinase. Urokinase. Okay. Now, from the name itself, it means that it breaks down clots, right? It breaks down fibrin. It breaks down your it breaks down your clot. And you usually use this in MI, right? In patients with MI as prophylaxis, or also pulmonary embolism maybe, but not maybe, I'm sure. Then, but we've talked about this earlier on, that the problem with streptokinase, we have started to understand the problem with streptokinase and start to not prefer to use streptokinase when it comes to treatment of MI, for example, or pulmonary embolism, for example. Although we want to break the clot that is formed in the body or wherever it is now, they don't really prefer to use streptokinase now, because streptokinase was actually taken from the factor of pathogenicity of Streptococcus itself. Because it is something that is foreign and belongs to a bacteria, the immune system that the immune system might attack that drug, right? Because we streptococcus infection is very common. Everybody got sore throat before, everybody got flu before, everybody got some form of something here and there, and they are all caused by most of them are caused by your streptococci. And all these streptococci, they have streptokinase, right? And because of this, your immune system is already familiar with streptokinase. And if the patient has MI and you are giving streptokinase to treat or to break the clot, it might not even work anymore because the immune system has already broken down your um, strepto your streptokinase. That is why streptokinase now is already slow. We are slowly phasing out streptokinase, and we use Altiplus. The what Shasha said earlier. The second name, Altiplus. Another name for it is TPA, tissue plasminogen activator. The same thing, Altiplus. Urokinase is also the same story as streptokinase as well. So that is why it is slowly being phased out and not being used. Hopefully they'll produce more or better thrombolytics in the future. Who knows? But anyway, that is streptokinase. Yeah. So what streptokinase does in streptococci? It is an enzyme that breaks down fibrin or breaks down clot. It transforms fibrinogen into fibrin, and oh sorry, it not fibrin, it transform plasminogen into plasmin, and plasmin is the one that breaks down the clot, it is not the streptokinase itself but the plasmin itself. So as the clot is broken down, it is now easier for streptococcus, the focus of infection, to now spread around. That is the purpose of streptokinase. Very smart, right? Streptococci, they just break something up, then use something to carry themselves around the body. Very smart. So that is why, yeah, it's a bit dangerous. Next is DNAase. DNAase, enzyme that breaks down DNA. I think the name is quite clear. Any questions so far before we move on?
No.
Nope.
Wait, what does it mean, DNS?
DNA dash ase. Enzymes, the endings are ase. So there are enzymes that break down DNA that breaks the double bond. Not double bond, the double-stranded DNA.
And DNA of what?
DNA of our tissues or the specific target organ.
Okay.
1 second. Uh-huh. All right. Now that everybody understands the microbiology behind Streptococcus, let's start talking about rheumatic fever. Let's start talking about. Can't find something that is nice. Anyway, I'm just going to read mine out because I can't find anything nicer. All right. Rheumatic fever. Rheumatic fever. It is a group of, it is a multi-systemic, non-suppurative disease. Multi-systemic, non-suppurative disease. We'll talk about why it's multi-systemic because it affects different organs in the body. And it is always post streptococci infection, 3 to 4 weeks after um, any streptococci infection. It can be pharyngitis, it can be tonsillitis, it can be any group A streptococcus infection, or even history of rheumatic fever itself. The term rheumatic fever, sometimes people call it acute rheumatic fever. Sometimes people call it chronic rheumatic fever. Uh, it's a bit it's a bit ambiguous there because what is acute and what is chronic is a bit difficult to distinguish there, because sometimes some of the clinical manifestation is a bit longer and we are not really sure whether it's actually acute or chronic. But if it's still within 3-4 weeks, I believe it is still considered acute. Now, the so what happens? All right, let's before we start talking about that diagnosis, what happens is that the focus of the infection, let's say pharyngitis or tonsillitis, right? The focus of the infection, for example, is in the throat, and there's already um, the the immune response has already been mobilized to get rid of that infection, be it macrophages or be it the production of antibodies, um, and whatnot. Well, basically, the body has already reacted to it and to get rid of the streptococci infection. Most of the infection, about 97% of the infection, will result in remission and the full recovery of the patient with tonsillitis or pharyngitis. However, for patients, a small percentage of patients, there will be other problems that it's going to be related to that. And scary enough, this percentage is getting higher and higher every year. They say it's 97% will be fine. 3%, about 3% will not be that well, but well, the numbers, I'm not really sure about the numbers, but it's we have to be careful with the 3% and then the growing 3%. And what do I mean is that the streptococci, specifically the M protein that we talked about earlier on, one of the factor of virulence, the M protein looks like a lot of our tissues in our body. And because of this, our immune system start to um, attack our own body, the patient's body. It means that rheumatic fever is multi-systemic, immune mediated, non-suppurative in disease, 3 to 4 weeks post strepto 3 to 4 weeks post streptococcus infection, right? So why it is not the infection itself that is causing rheumatic fever, but it's the immune system that is now attacking our own body, the body itself, and you can say that it is an autoimmune disease. And because M protein looks like our own tissues, and this phenomenon is called antigenic mimicry or molecular mimicry, up to you, whichever you want to use. Mimicry, you know, mimicry, right? Something that mimics each other, that mirrors each other, that looks like each other. Because of this, there are a number of organs that can be involved. Now, I'm sure most of us are familiar with the Jones criteria or rheumatic fever, or revised or modified criteria, Jones criteria. I'm sure most of us have heard of that before, right? So one way to remember Jones criteria, when it comes to autoimmune diseases or rheumatology criteria, there are, of course, major criteria and minor criteria. Now, a good way to remember Jones criteria, let me write this down, N-E-S. If you are writing, you can write it like this. J, O, instead of O, you can write a heart. Then N-E-S. Why is it showing upside down on my screen? But J-O-N-E-S. Okay. J is for joints. Actually, joints is a name. It's not actually an acronym, but anyway. J, joints. The O, the heart, means heart, of course. N would be nodules. N would be nodules. E would be erythema marginatum. S would be Sydenham chorea. All right, we're going to talk about them one by one, okay? And understand how it happens. Why is it here? Why is it that? Why is it this? Okay, let's start with J. This, by the way, this 1, 2, 3, 1, 2, 3, 4, 5, these 5 major criteria, they are all major criteria, right? Okay, before we move on, let's all write down minor criteria, okay? I tried looking up for a nice picture of all of the points in the criteria, but I can't find any nice pictures, so I'm just going to say it out, okay? Minor criteria include fever, arthralgia, prolonged PQ interval, which means AB block, yeah? Prolonged PQ interval, increase in ESR, CRP, and WBC, or your white blood cell. Increase in ESR, CRP, C-reactive protein, and your white blood count, white blood cell. These are minor criteria. And remember them because they are a little bit related to your major criteria. Okay, let's start with joints. J, major criteria. Now the thing about joints is that the synovial membrane, the tissues in the synovial membrane looks like the M protein that we talked about early on, and the immune system starts attacking the synovial membrane, causing inflammation of the synovial membrane in the joints, or in other words, synovitis, right? And after a while, let's before talking about other characteristic, the thing about synovitis is that, or pain, or sorry, or the problems in the joint, is that know that in the joint, because what am I saying? The problem is that when the immune system starts attacking the connective tissues, and the synovial membrane starts to become inflamed, it will lead to arthritis, right? Inflammation of the joint itself. Now, from the term itself, arthritis, inflammation, right? It means there will be inflammatory signs there, not just pain. The joint will be painful, will be swollen, can be red, when you touch, you might feel some increase in temperature on the joints. It can be tender as well. Now, what's the difference between pain and tender? You know, these are also another two terms that we often hear, especially when, for example, when we palpate the abdomen, right? When we say, "Oh, tender abdomen," does that mean it's painful? Does not mean, does what's the difference between tender abdomen and painful abdomen, right? From the name itself, painful. It means that the patient, him or herself feel pain, right? However, tenderness is when palpation is done and the pain is felt upon that palpation. That's what tender means. It means it's soft. It's soft. I mean, soft abdomen. It's a different meaning, of course. But what the name tender means, something that is gentle, that is something that is very volatile, something that is that that is not stable. So, but basically, it means that upon palpation, upon touch, it is painful, right? And just because it is tender does not mean that the patient feels pain on himself. Like, for example, right now, let's say um, let's say I have a bruise on my leg, right? If I don't touch the bruise, it might not be painful. But when I touch the bruise, it feels painful. It means that it's tender, right? Okay. But anyway, I hope I'm making sense. So if there are signs of inflammation, it means that it is arthritis. But if there are no signs of inflammation and it is only pain, if it is only pain, it means it's arthralgia. Why is it important? It's because arthralgia is in your minor criteria and not your major criteria. So when you want to diagnose if the patient feels pain without any signs of inflammation, it's arthralgia, and it's minor criteria and not major. All right, next, still talking about joint. The another feature of the
So, Norman,
yeah.
please explain. Meaning, what differentiates arthralgia from arthritis is that inflammation, right?
Mm-hmm.
Okay, thank you.
If it is not tender, if
Yeah,
it is not inflamed, if it is not swollen, if it's
yeah,
not red, it's
arthralgia.
arthralgia.
Thanks.
Okay. Another feature of arthritis is that it is it's multiple in nature. So polyarthritis, right? It occurs in different joints, not just one joint. It can be symmetrical, it can be asymmetrical, and it affects many joints at once. So polyarthritis. Next feature of still in joints is that it's migrating. For example, the patient might feel pain on the knee joint symmetrically for a while. Then after 2-3 days, the pain is gone. The pain is gone. Then suddenly his ankle joint feels painful. Now after 3-4 days, after 5 days, it's gone. Suddenly the wrist feels painful. So it is migratory in nature. That is why the full term for it is migratory or migrating polyarthritis. This is the first major criteria. Okay, understand? Right. So another issue that we need to clarify when it comes to these features is that sometimes when the patient comes to you and maybe still early stages of rheumatic fever, and you don't know if it's migrating or not. It can be polyarthritis, okay, sure. Or arthralgia, sure, okay. But then whether it's migrating or not, you still need to be sure, right? And you have to be sure of your diagnosis, because we'll talk about this later on. Once you put acute rheumatic fever as your diagnosis, there are social repercussions to this. There are a lot of clinical repercussions to this. So it is extremely important that you are sure that this is your diagnosis, or else in the future, this patient will need to face a lot of treatment, a lot of prophylaxis, a lot of a lot of things that they have to consider in the future. So that is why you right now, if you misdiagnose or underdiagnose or overdiagnose, there'll be a problem. Um, so the migrating nature of the polyarthritis, how can you be sure? If you are still not sure whether it's migratory in nature or not, it means that you don't prescribe painkillers yet. You don't give aspirin yet. You can give maybe very mild sedative drug, just to calm the kid. Again, remember, this is a kid, right? It calms the kid down. For example, giving codeine. Codeine is a cough drug. Giving codeine, um, it sedates the patient for a bit, so the patient might feel better and might not be able to still judge that the pain is still there. But as you can tell your guard the parents as well, that because you are not sure whether this is migrating or not, and you want to be sure that this is migrating, and that you want to be sure that this is the diagnosis you want to put. Um, so right now, we'll prescribe maybe codeine, or not prescribe anything at all. And if it is migrating, you can be sure that it's migrating in nature. Then you come back to tell them, come back to me again. All right, now we can be sure that this is we can tick a box in the major criteria that this is acute rheumatic fever. By
Please,
the way, yeah.
please, for a case, is there any other drug apart from codeine? Because at the moment, like in Nigeria, codeine is highly restricted.
Agree.
So, yeah. So is there any other drug apart from codeine?
Codeine itself, it's a controlled medication. Of course, it is a controlled medication, because we are the problem of addiction.
Yeah,
There are a
exactly.
lot, a lot of drug addicts. They are they enjoy codeine. And it but the thing is that, if you don't want to give any sedation, uh I don't think there are any other. I don't For me, at least for right now, I can't think of any other sedation, other non-aggressive sedation rather than giving codeine, because codeine for kids is not as strong as codeine for adults.
Yeah.
The syrup that you give kids containing codeine, it's quite low.
Okay.
So hopefully it works. If it doesn't work, just not don't give any painkillers, don't give anything at all.
Okay. Thank you.
Uh-huh. Where was I? Right. Okay. Joints. Migrating polyarthritis, right? Did I miss out on anything? I don't think I've missed out on anything. All right, next. Heart. J. After J is O. Your heart, right? Carditis. Carditis. It refers to all layers, any form of carditis for that patient. It can be pericarditis. It can be myocarditis. it can be endocarditis, any of those things that we've talked about earlier on. Remember, we talked about endocarditis, all those things. It can cause that. So if we start talking about the second criteria, the heart, it will be a very long lecture again. But yeah, just bear in mind carditis, it can be acute, it can be a pleural effusion, your pericardial effusion, your infective endocarditis and all that. This can cause that. Remember when we talk about all these diseases, pericardial diseases, they are there are multiple causes, and your rheumatic fever is just one of them. It's just one of them, okay? Now, another point I want to talk about carditis is the endocarditis part of rheumatic fever. Valvular heart diseases is a very common long-term manifestation of rheumatic fever. The vegetations that we talked about when we talk about the hemodynamic changes in valvular heart diseases is in here too. But this is a long-term effect, a long-term effect. They are saying that joints, the inflammation in joints, once it's resolved, there are no long-term side effects, and that's the good news about it. I'm not sure whether it still is right now, but about the heart, there is a long-term repercussion that we have to bear in mind. Okay, valvular heart diseases, it's a chronic process. If not detected or not treated early, it can lead to heart failure as well. So it's also, again, it's a cascade of problems. Next, subcutaneous nodules, N. Next criteria, N. The connective tissues in your subcutaneous layer also mimics the M protein, and the immune system starts attacking all these subcutaneous tissues, and they form small like nodules on under the subcutaneous layer, and it is often on the extensor part of the hand. The size is about like a bean, like a pea, and sometimes it can be single, sometimes it can be multiple, and all that. But and also it's painless. It's painless. And when it comes to nodules, if you would like to describe the nodule, you can use the ABCDE way to describe the nodule. Of course, if you're familiar with ABCDE, actually it's not a way to describe skin lesions, because the ABCDE way to describe your skin lesions actually for melanoma, remember? And I think we've heard of the ABCDE way of describing skin lesions. I think we studied it in propageetics, that first, in the first few classes. And then if you've had oncology cycle, we've also heard about the ABCDE way of describing melanoma, the same way as well. So the same way you want to describe nodules, you can say whether it's elevated, the size and the borders and stuff like that. Feel free to describe your nodules that way. Anyway, those are subcutaneous nodules, yeah? Now E, one we've talked about JON. E, erythema marginatum. Erythema marginatum. From the name itself, erythema, it means redness of skin, yeah? Now, the term marginatum, so from the name marginatum, you can understand this something related to margins, right? So how is this manifested? Is that it will begin as like macular skin lesions, and after a while, the center of the macula will start to heal, leaving the edges red. That is why the name is erythema marginatum, because the margins are still red, or sometimes it looks like a crescent moon, like this, right? Inside it's clear, but the borders are still red. And it is often found on the central part of the body rather than peripheral, and not the flanks. Flanks, okay, fine, a little bit on the flanks, but central region and not on your extremities. So this is erythema marginatum. Next is chorea, Sydenham chorea, S, last major criteria, Sydenham criteria, Sydenham, apostrophe S, chorea. Another name for it is Saint Vitus dance. Synonymous, but Sydenham chorea is something that's more commonly used. All right. So what is Korea? It's not the country Korea, it's Chorea. What is it? It is an uncoordinated, purposeless movement of the body. Uncoordinated, purposeless movement of the body. So it means that it affects the CNS, yeah? And the part that governs the movement or the motor system is the basal ganglia. And unfortunately, it looks like the immune system thinks that the basal ganglia looks like the M protein of Streptococcus and starts attacking it. And because it starts to become inflamed and become uncoordinated and disbalanced, the the governance of basal ganglia over the motor system is now being affected, and the motor system is now uncoordinated. It means that because it just imagine a parliamentary house, or for example White House under attack by, I don't know, some terrorists or something. Everybody's just panicking and stuff like that. Just imagine it like that, and everybody just wants to protect the president. Some just want to run away and stuff like that. So imagine that happens. So the the explosion of the electricity motor response is now very erratic and uncontrolled. So the movement can be just like that person can just move like that for no particular reason, and that person looks like he's dancing, and it's purposeless. There's no point in doing it. There's no intention behind it. And this is a very characteristic thing for rheumatic fever. Of course, there are different causes of Sydenham chorea too. If you revise or you study psychiatry, there are different factors. There are different things that can cause Sydenham chorea too, but this is one of them too. All right. These are all five criterias for five major criterias for rheumatic fever. We've talked about minor criteria, we've listed them out already, and we I don't think there's a need to explain any of them because I think they're pretty clear. I've already explained about arthralgia and the importance to distinguish arthralgia and arthritis, migratory arthritis. Fever is usually low grade, it's not very high. Prolonged peaky interval means some form of AV block, and which I also explained. Increase in ESR, RCP, these are inflammatory markers. Increase in WBC, your white blood count increase. These are just inflammatory markers. They are minor criteria. So how to place your diagnosis is two major criteria or one major, before going to diagnosis, besides major and minor criteria, there's also another criteria to fit into the picture, and that is the evidence of any recent group A streptococcus infection, GAS infections, group A streptococcus infection, any evidence of it. That means you can write this down. Number one, positive throat culture. It means you take you test it out. Then after a couple of days, the culture comes back positive. Positive test culture. Second, anti-streptolysin O, increase in anti-streptolysin O titer. Remember in our factor of virulence, we talked about the factors that can hemolyze, right? And streptolysin O and streptolysin S. And if you can see the increase in anti-streptolysin O titer, it means that antibodies against it, it means that there's a recent infection. Next is anti-DNAase. We talked about the one of them, right? And DNAase or anti-deoxyribonucleic acid ACE. Next would be rapid streptococcus antigen test positive. Rapid, just like COVID test, there's swab test also. There's also rapid test. There's also some rapid tests for streptococcus infection as well. And lastly, recent scarlet fever. Recent scarlet fever.
Norman,
Mm.
can you repeat the fourth point? A rapid what?
Rapid streptococcal antigen test. Everybody got it? Do I have to repeat any of the 1, 2, 3, 4, 5 evidences of recent gas infection? Group A streptococcus infection. No?
Can I repeat?
Repeat? Okay.
Mhm.
First, positive throat culture swab. Second, anti-streptolysin O titer increase. Third, increase in anti-DNase, anti-deoxyribonucleic acid ACE. Fourth, rapid streptococcal antigen test. Fifth, recent scarlet fever. Evidences. Okay. To put your diagnosis, number one, you can have two major criteria plus evidence, or one major criteria, two minor plus evidence. One major criteria, two minor plus evidence. This is for the first episode, like firstly diagnosed. If the patient comes in with recurrent acute rheumatic fever, the criteria is different. So if there is no manifestation of rheumatic heart diseases, meaning valvular heart diseases, if there are no manifestation of that, the criteria is the same as firstly diagnosed rheumatic fever. The what I said earlier on. Two major evidence, one major, two minor evidence. The same one. However, if if there are signs of rheumatic heart diseases, meaning you can hear murmurs already, meaning the heart sounds are already muffled, or you when you perform physical examination before sending your investigation, you already can detect maybe enlargement of some part of the heart, cardiomegaly or just left ventricular hypertrophy and whatnot. Those are the manifestation of it. If that is seen, you need two minor and one evidence. No need, there's no need for major. Two minor and evidence. Question?
Can you repeat your last sentence because you were breaking up?
Okay. If there is manifestation of rheumatic heart diseases, if there is if there are signs of rheumatic heart diseases, that is valvular heart diseases, you need two minor and one evidence. And two minor and your evidence, not just one evidence, and your evidence. Okay, clear? So there are three ways to put your diagnosis. One is firstly diagnose. Second is whether it is recurrent rheumatic fever, and if it's recurrent, whether there is any manifestation of rheumatic heart fever, rheumatic heart diseases, or with manifestation of rheumatic heart disease. Okay, clear? All right.
Norman,
Mm.
what does muffled heart sound mean?
Muffled means uh, it is not clear. Let's see, how can I describe this? Imagine someone holding a microphone, okay, without just like this microphone, right? It's very clear. You can hear every single click, every single rise and fall, every single mispronunciation of that person, and all that. But let's say you take a towel and you put it over the microphone, or when you talk to someone on the phone, right? Then it's clear. But if you close your mouth, it sounds very something like that. I don't know how to properly describe, but I hope I'm making sense. That is
Okay.
what muffled means. It
Alright.
is a bit.
Is it the same of decrease intensity of
No,
each
it's
sound?
not the same. Intensity can decrease, but the sound can still be clear. It may not be muffled. Muffled means that it's already difficult to hear like very clearly already.
Mm,
Okay.
yes.
All right. Let's talk about treatment. Let's talk about treatment now. Treatment can be divided into three for rheumatic fever approaches to treat it. Number one is to manage the acute attack, which is your rheumatic fever. Manage the major criteria, minor criteria, manage that. Second is to manage the current infection. If there's pharyngitis, tonsillitis, or otitis media and stuff like that, if you can manage that, that's the second approach, second way to manage, which sometimes also fall simultaneously. And third is prevention. Third is prevention. Now, your acute attack. Now all of this you're already sure of the diagnosis. You're already sure of the diagnosis, right? You're 100%. So you can give your NSAIDs, any NSAIDs you like. You can give aspirin, uh, any NSAIDs, sure. Why not? Why not? Just any NSAIDs. But of course, remember that these are kids. You're treating kids. If you want to give other NSAIDs, is a bit might be a bit. You have to consider other things. So I can just give high dose aspirin, which is fine too. You give high aspirin until the pain disappears. Until the pain disappears. If it's arthritis, until it disappears. There's no specific duration and all that. If it does not disappear, continue. Because remember this thing, they are saying that after a while, it there's no long-term implication to it. So once it finishes, sure.
You say you give what?
What?
What do you
Aspirin.
give? Aspirin?
NSAIDs.
Okay.
Mm-hmm. Besides aspirin, you can give naproxen as well. There are also anti-inflammatory painkillers as well. If that does not work, you can give corticosteroids, of course, for to increase, to exponentiate, is that the word, to to increase the anti-inflammatory effect. You can give corticosteroid, prednisolone. All right, knowing that this is also, this can be the infection can, the streptococcus can still circulate in your system. Of course, the next one you have to give will be your antibiotics as well. Now, which antibiotic to give? We can't just throw whatever antibiotic you want to give. Traditionally, I've checked guidelines as well. Traditionally, you can give penicillins. Your methylpenicillin, they are saying you can give phenoxymethylpenicillin or benzathine benzyl penicillin. But remember, there are people who are also allergic to it, or to penicillins. Or if you don't want to give penicillins, honestly, I think clinically penicillins are a bit fishy to give because of resistance and all that. So if you don't want to give penicillins, you can give cephalosporins too. Any yours, no, you can't give all cephalosporins. You need to give third or fourth generation of cephalosporins. Remember, our cephalosporins, the first few generation is covers gram negative. Then as it becomes newer and newer, it covers more gram positive, right? And your streptococcus is gram positive. So you can give your ceftriaxone, cefepime, your third, fourth generation of ceftriaxone, your cephalosporin will be fine. If they are allergic to penicillins, of course you can't give cephalosporin too because cross-reaction. They are both beta-lactam antibiotics. So of course you can give your macrolides, your erythromycin, your why am I losing my words? Erythromycin, azithromycin, and what are the macrolides? Azithromycin, erythromycin, and
Gentamicin.
Gamithromycin. Clarithromycin.
clarithromycin, both. Clarithromycin. Oh my goodness, this is the holiday. Right. So you can give your erythrocytes too. Erythrocytes. Why don't you, your erythromycin, your macrolides. Okay. Of course, also bear in mind that the effects of carditis also you have to consider too, right? And if it develops into some form of heart failure, of course, you have to treat that as well. And treatment of heart failure will come into the picture here. We've talked about treatment heart failure, yeah? So you can, depending on the situation, you can just give everything. You overprescribe things in the end. But if needed, beta blockers. If needed, the diuretics. And all of these are just for any forms of, and if there is sign of heart failure. Now, if there is chorea, what can you give for chorea? You can give your diazepam. Your diazepam, carbamazepam, or you can give haloperidol. By the way, okay, let me just list out some drugs that you can give for chorea. Diazepam, haloperidol, phenobarbital, your barbiturates, or valproic acid, which is an anti-epileptic drug, valproic acid, or valproate, sodium valproate, the same thing. These are not in the guideline. These are off-label prescription, but they found it to be helpful for the chorea. So bear in mind that you have to be careful when you give. Of course, by the name off-label prescription. Okay. All right. Before we finish, we are already 5 minutes ahead of. We are already 5 minutes late already. We're supposed to end at 8:30. I want to talk about prophylaxis, and we'll finish with prophylaxis. Why is it important? Like I mentioned earlier on, it's important to be sure of your diagnosis, because if you overdiagnose, it means that you're going to put before talking about that. All right, let's talk about sorry for the confusion. Let's talk about prophylaxis first. Then I'll talk about the importance and blabber about how important it is about on your when it comes to diagnosis. Okay, first and foremost, there are different approaches um, this to prevent this from happening again. Remember, we talked about treatment three, right? Your management acute, current infection, and now your prophylaxis, your prevention. First, first approach to prevent acute rheumatic fever with no signs of carditis or infect infective post gas infection, post group A streptococcus infection without carditis. This is the first one. For this, the duration of prophylaxis is minimum 5 years after the last episode. Once the signs are already in remission or is already have already recovered, minimum 5 years of prophylaxis. What kind of prophylaxis you give? Your penicillins, your antibiotic, penicillin, cephalosporin, all those things. Prophylactically, intramuscular, and the dosage is the same as as um, uh, as ongoing infection. The same. It's just because it's prevention does not mean that it becomes low dose. Okay. Remember, bear in mind the same dosage. I'm not going to talk about what dosage because I guess different countries have different dosage. All right, minimum 5 years after last episode, or until the age of 18, or for some, according to Sarajev, he said 21. Age of 18 to 21 depends on where you are. Remember, this is a pediatric problem, right? So if a patient in between 5 to 15 most often, so up until 18 or 21 years. This is with no carditis manifestation. Second, mild to moderate rheumatic heart disease plus or post-infective gas infection with carditis. Mild moderate rheumatic heart disease or post-infective post gas infection with carditis. Minimum 10 years after last episode of acute rheumatic fever, or until the so-called mature age, and that is approximately 25.
Norman, can you repeat the second part?
Mild to moderate rheumatic heart disease. You can see rheumatic heart diseases already, valvular heart diseases in other words. Mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, itak dali. Or post-gas infection, gas is GAS, group A streptococcus infection with carditis. Any carditis, remember, acute pericarditis, all three layers, any of the three layers, or even pancarditis, all three, endo, myo, and peri. Okay, minimum 10 years after last episode of acute rheumatic fever until mature age, also called 25. Third point, severe rheumatic heart disease, severe rheumatic heart diseases, post or post cardiac surgery after formation of any valve defect, severe rheumatic heart diseases. And how do you decide severe or not? It's based on your echocardiogram, remember? Based on your echocardiogram, based on what ejection volume, based on the degree of stenosis, if it's stenosis, regurgitation, how what's the pressure, that the stroke volume, or all those things you have to consider. That's how you decide whether it's mild, moderate, or severe rheumatic heart disease or valvular heart diseases. Severe rheumatic heart diseases, post-cardiac surgery after formation of valve defects. Now, what is the duration of prophylaxis? Unfortunately, it is lifelong. Lifelong. Or until the age of 40. But then again, it's very rare for it to not manifest again, especially after the age of 40. Your it's very rare, honestly, to everything to be in remission after the age of 40. Lifelong prophylaxis plus lifelong warfarin. Okay. So from hearing all of this, now can you feel the weight of putting your diagnosis?
Yes.
Right. You can already feel the weight of your diagnosis. If you overdiagnose, this is what your patient is going to go through. If you underdiagnose, there are also long-term manifestation, especially the heart. Maybe you might not be concerned about other organs like joints or nodules or your erythema manginatum or your chorea, but your heart, big problem. Your valvular heart diseases, big problem. Okay. All right. Now that that is clear, I don't think I have other points to talk about. So, do you have any questions?
I have a question.
Mm.
Or you talked about using NSAIDs like aspirin, right?
Mm-hmm.
Since one of the side effects of aspirin is that it can cause gastrointestinal ulceration. So what do we do? As in, how do we?
Prevent
You
that.
said, for example, we use it till um, the symptoms are over now.
Mm-hmm.
So
So
is
it
it that?
means, yep,
Yeah,
possible.
yeah. What I'm saying is, since sometimes aspirin can have some side effects, is it that in this case it might not have such side effects?
It definitely will. It definitely will. Any NSAIDs, especially aspirin. Remember when it comes to even the problem of MI,
Mm.
after giving aspirin for a short period of time, you switch from aspirin into why is my brain not working? uh what's the next drug that you can use? Ticagrelor. Um oh yeah, help me. Diclofenac, not diclofenac. Uh what other anti-aggregants that you can use? Oh my goodness. How can I forget? It's a very common name. Anybody come?
Clopidogrel.
Clopidogrel. Clopidogrel. Clopidogrel. Clopidogrel, yes. The same. That is why you switch it to clopidogrel, because you are scared of the ulcerative effects of NSAID. But because of your concerns with it being ulcerogenic, so it means you can give either you tell the patient, okay, this is what happens if you don't if you take it incorrectly. So you have to take it with food, make sure that your stomach is full, especially when you take aspirin because of the effect and all that. And yeah, if you're scared of that, you can give proton pump inhibitors too, just to make sure that your stomach is not that it's not aggressive to your stomach. Or you can sometimes take antacid as well, just to protect the lining of your stomach. Another one that you have to be scared of, not just the ulcerogenic effects of NSAIDs. Remember, these are NSAIDs, right? But aspirin itself also increases your chance of bleeding. Any anti-aggregants and any they are not anticoagulants, and anti-aggregants. Anti-aggregants, that's the Russian name for it. Any giving anti-aggregants would increase your chance of bleeding as well. It means that sometimes your nose might bleed. You might have you suddenly have hemorrhoids, even if you don't have hemorrhoids and all that. It happens as well that long-term use of aspirin and long-term use of clopidogrel or ticagrelor. So you have to be careful with that too. And when that happens, you're gonna have to stop the medication. You have to stop.
Okay, спасибо.
Okay. Any other questions?
Naman, you said we can't underdiagnose and overdiagnose. So how do we diagnose?
We can't overdiagnose and we can't overdiagnose. Okay, what do I mean by overdiagnose? It means that you're just so hypersensitive that you are scared it's rheumatic fever. So you just want to put the diagnosis because you're scared to be wrong. So for example, joints just now, you might not know, you might see pain only. Oh, it's arthritis already. Okay, so let me just tick one major criteria when it's only arthralgia. For example, let's say, what are the things that we can be wrong? Let's say pericarditis, for example, right? Let's say pericarditis, and you see that the heart is not, it's quite okay, but we see increasing ESR, CRP, inflammatory markers, and post and also okay, maybe let's not talk about the criteria. Let's say for example just pharyngitis, and you know it's streptococcus, and you're like, okay, I'm scared of rheumatic fever, and suddenly the patient comes in feeling chest pain, and you're like, oh, all right, this is rheumatic fever manifestation of the initiation of the manifestation of rheumatic fever. Then okay, you put the diagnosis already. That's overdiagnosed. But then again, being underdiagnosed here means that you understand that you can overdiagnose, but you are just you are very particular about your diagnosis. So what am I going to what am I reaching right here? Let me think. Oh my goodness, Norman. Underdiagnosed. Where was I going just now? Underdiagnosed. Okay. All right. It means it means that you've missed the diagnosis. The signs and symptoms are clear, but you might think of something else. So that's what underdiagnosed mean, or I think probably misused the word underdiagnosed. I probably misdiagnosed here will be a better term to use. So I hope that's clear. I hope I did not confuse you with overdiagnosed and underdiagnosed.
Yeah, I
So
got
how
it.
do
I got it.
okay. All right. Any other questions? No? Хорошо. If there are no questions, thank you for joining today. I'll think about what to cover next week. Maybe we should cover cardiomyopathy next week. Adult cardiomyopathy, not adult, congenital. See, my head is all around. Maybe we'll talk about cardiomyopathy and congenital heart defects, adult congenital heart defects, if time permits.
Right.
All right. If there are no questions, sorry that you're welcome. Sorry that we've overshoot by 20 minutes.
No problem.
Thank you.
All right. Take care. Enjoy your holiday.
Bye.
I hope that everybody sharpens their thoughts and not get confused like me.
Thank
All right.
you.
Bye-bye.
Bye.